This is a 15-year-old male status post dirt bike injury with a right open Salter Harris 2 distal tibia and fibula fracture. He was given ANSEP and tetanus, provisionally washed out and splinted. It was taken first case in the morning for a right ankle IND and ORIF. He was then placed into a bivalve long leg cast and made that weight bearing.
So what are you worried about with that fracture?
Say that again?
What are you worried about with that fracture?
I mean, he's 15. Obviously, his spices are still open. I don't think there's his spices is going to close. We'll probably get no more growth from that. Other things, I mean, open fractures. You're worried about. There's a low infection risk. I'm not sure what else.
Yeah, definitely infection, of course. But yeah, so we've studied this, not me, but this has been studied here at this institution in terms of growth arrest. So let's say he was 13 and he had this fracture.
Yeah, so if he was 13, you get about 5 millimeters per year from the distal tibia. Then you'd have about 3 years left to grow if he's a male. So you would get some growth arrest and maybe looking at like 1.5 centimeters of potential leg length discrepancy, but certainly would be more of a concern if he was a little younger.
Agreed. And one of the, yes, so good answer. And then one of the other things I took away from the study here at this institution was that the number of reductions matters. So you want, if you are going to reduce, if this wasn't open, if you were going to reduce it definitively, you get one good attempt really there before you start causing problems. So
yeah,
you want to get the proper sedation and do it in the proper setting and get a good reduction. If there's any PD pods in the office, in the audience, please, correct me if I'm wrong, but my understanding is you get one good attempt at that.
Yeah, certainly. That's the, whenever we see these and they're closed in the emergency department, we make sure that we get, adequate sedation and you really try to nail it on your first try.
How big was the opening?
It was about 2 centimeters anterior medially.
And it was a dirt bike, you said?
Yeah.
Is that a low velocity or high velocity type of an injury?
I would say high velocity, probably, type 3 by mechanism, I guess, if you consider the dirt bike high energy.
So it's a 3A?
Yeah.
And how long between the injury and the time that you washed it out?
So he was transferred from Capitol Health in the evening. He was given ANSEF at the time at the outside hospital. The transfer center actually never closed; it was open, but it was within 12 hours of the injury that he was taking the OR.
You said you took it the next morning.
Correct. So it happened at night. He was, it happened I think around like 6 or 7 p.m. So he was taking. It was right around the 12-hour mark. We took it right at 6:30.
I mean, there's no evidence to support, that except so there was a recent systematic review about these real mangling open fractures. And this is maybe one of them, but there's no definitive evidence to say that taking these to the OR within any certain point of time really matters. I mean, I think that most of these, the standard of care is definitely, I think what you did is definitely within standard of care. But within 24, I think is the absolute limit that people would say.
As far as growth goes at that distal physis, it's probably less than 5 millimeters a year. It's probably more like 3 to 4 millimeters a year. And as far as the repercussions of that in an adolescent, limb length discrepancy is not on the radar as much as angular deformity. So when you watch these every 4 to 6 months after internal fixation, you're looking for angular partial growth arrest, not complete growth arrest. Or asymmetric growth arrest between the fibula and the tibia, causing an angular deformity of the ankle. So limb length discrepancy is almost never a complication, but asymmetric growth arrest and angular asymmetric growth is a probability in about 15% of these kids.
Is there ever
Phil,
any
can that be done
syndesmotic
with a-
injury with these?
I'm sorry, there were two questions. What?
Saying, there was in an adult with a high fibula, you're worried about syndesmosis. Does that happen in kids? I mean, I don't know. I'm asking.
Oh, I guess, yeah, I'm not a syndesmosis expert. You guys see all those injuries. And I'm sure the syndesmosis gets affected just as much as in adults, but for kids, you're going to immobilize this kid. You're not worried about early range of motion in adolescents and children like you are in adults. So in adults, you're going to be fixing a lot of syndesmosis injuries and not worry about immobilization. A lot of these kids, I'll put them in. I mean, this kid will definitely be in a cast, and sometimes I'll even use a long leg cast in a non-compliant 15-year-old boy who's going to do everything I tell him not to do. So the cast immobilization after these injuries will, treat the syndesmosis if you're not fixing it surgically. But we certainly will immobilize kids a lot differently than we do for adults.
Phil, Tim Letty here. My question was going to be, do you have to have a special study or just a standard x-ray is sufficient to measure for any angular deformity? I mean, obviously a scanogram if you're looking for a leg length, but you don't need to do that every time you monitor that kid, right?
Right. I don't use scanograms to follow limb length discrepancy post-traumatic. I follow them clinically. I think, after a few years of experience, a good pediatric orthopedist can just measure limb lengths clinically, standing on blocks, that's probably the best way to follow limb length discrepancy. To follow angular deformity, asymmetric closure, you can pick it up with just a standing AP radiograph, standing lateral radiograph. And I do that every 6 months. And it's pretty easy to do. You get both ankles on the same cassette. And you can see an early closure before you can pick it up clinically. You can pick it up radiographically, and then you can follow them every 4 months. Once you pick it up, on your 6 month, actually, you can follow them more closely to see if you're going to need to intervene surgically.